Okay, Professor Yar, I think that we may start with our webinar. First of all, my name is Antonino Galliani. I'm working for Teethan, and we are hosting this webinar with Professor Riaz Yar, who is with us. Dr. Yar already did a webinar with us 2 years ago, talking about comprehensive restorative care. I will put the link if someone after this webinar want to take a look to the webinar about CRC. We'll put the link, the YouTube link on this on the chat. Professor Yar is specialized in oral rehabilitation, or he had a master in the University of Bologna. And he is a professor in prosthodontics at the University of Birmingham and at the Ulster University as well. In this webinar, Professor Yar will talk about how to use, how the muscles are important in oral rehabilitation, and also take a look to two very important clinical cases that he brought us. From the important of using Teethan in the very first visit, and to follow up the patient all along oral rehabilitation. So before starting the webinar, so thanks a lot to everyone from me here, and Doctor, I will leave you the floor for the webinar. Already the screen is shared, so you can start. Thanks a lot, and enjoy these clinical cases. Thank you. Thanks, Doctor.
Thank you, Antonino, and thank you, Teethan, for asking me to share what experience I have with Teethan. I've had it now a couple of years, and the title is motion guided, but I think of it more of an evolution of occlusion. So he already sort of introduced me there. I'm a sort of a specialist in prosthodontics in the UK, and a visiting professor at the College of Medicine Dentistry in Birmingham with Ulster University. And a lot of my things, I like research, so I like to do a lot of research with what I'm doing. So the aim of today is to try and get you to understand motion and the importance of muscles within that motion, and how that works with teeth. So for me, they are not separate, they're all interrelated. And we want to be able to make our sort of data collection more objective rather than less subjective. So we have data now. When we think about knowledge and how we progress through learning, we tend to be more dentists tend to be more left brain, whereas the right brain is more of the artistic side. So when I think about the sort of evolution of occlusion, and I think about how we restore our patients, we can do it simple way, which is you just build the teeth up and try and get it to fit, but the function is potentially affected. When we think about dentistry and restoration, it is the use of mechanical devices that makes it the only way we restore. But I'm thinking more about rehabilitation. How do I rehabilitate the patient? And so I use the Teethan EMG, I use Modjaw, I use other tools to help me at this stage analyze my patient. So when I have a patient, what I'm doing in my process is sort of a 6-step process. We are doing one, understanding the desires of the patient. And number 2, I'm doing what is called a suitability assessment. So we are doing a detailed analysis, both from TMJ assessment, muscle assessment, and teeth assessment. And I use multiple tools to do that. One of them is Teethan. And for me, it's essential in validating that I've got the teeth in the right place. We then look at what they can afford, if they are the affordable option is available to them. Then we do a mock-up, we put them into provisionals, and then we copy and deliver that into the finals. And this is sort of what I'm thinking in my design. So when I think about restorations and how the muscles dictate the shape of the restorations, You know, when we first started doing dentistry, we were using very sort of basic articulators, and the teeth that we used to design were very, very flat, very, very worn. And now when we do cases, we look at rehabilitating our patients from this to the end result. You see, I can show you the end result, but this is again very subjective. You know, how do we know that the patient got better? Did we make things better for the patient? Because this is the starting position. These were the patient's starting position, and this is the patient's end position. But this is all very objective. So we need to make it more data collection wise. When we understand how teeth touch, they enter the brain assimilates that from the tooth data, and it says, you know, I need to apply more force. So this is where the muscle link is so important. So the teeth provides the data for the muscles, and the muscles generate the force to break the food down. It is also a safety mechanism, because if you bite on something hard, then you realize very quickly, you know, I need to open. We learn from that. So for example, when I'm doing, you're biting on an olive, then you know with olives that you know that they don't have seeds in it. If it says on the actual device, no seeds. If it says on the box, no seeds, then you are going, okay, I can bite hard on this. But when we have surprise, we have to have a protection. And what that happens is the cerebral cortex, the cerebellum, that memorizes that. It's called feed-forward learning. So this process interlinks with teeth, because teeth are very, very sensitive. The range is 8 to 60 microns. The threshold changes when we chew, because we don't want to be chewing with attention. We want to be chewing being relaxed, not thinking about it. And it's only when you are trying something new that you suddenly become attentive, you know, trying a new food, for example. But chewing isn't just apical and coronal pressure. It is interdental. It is also mesial distal. So the teeth are sensitive in all 4 planes. That tells us a lot about teeth. But that relates to function. And when we look at this article here, you see here that on the left picture, the patient was biting into a nut with natural teeth. Look at how they bit. The nut is very clean. There's no remnants there. And the movement is very smooth. Look what happened when it was a bridge. Tooth-supported fixed prosthesis. This one, the patient built in protection. They knew that it's not their natural teeth and they don't want to damage it. So it built in a protection mechanism. So it became very narrow in its motion. So when we look at implants, we start to lose the control, the finesse of the movement, and look at how it breaks the nut. Now, this is important for teeth, because when I design the teeth, I want to know that the muscles are going to react favorably to that. And so then the motion should improve from the muscle perspective. So we started to look at different articulators. This is the semi-adjustable. And we are very lucky. We're very lucky that our patients adapt. But adaptation can be negative and it can be positive. So when we think about all the principles that we have applied in occlusion, is that to protect the restoration because we know our patients can adapt? Or is it to protect the material that we're using so it doesn't break? So a lot of our principles are based on protection, not function. And I use this as an example because this case here, the patient came in, I did a full upper arch rehab. So the patient has walked away very happy with his smile. And I introduced a non-working side contact on the teeth. So he is chewing on the left and the right teeth are touching. So if you watch here, as the patient is chewing on the left side, his right side of the teeth are touching first. So when you chew on the right side, you want the right teeth to touch first. When you chew on the left side, you want the left teeth to touch first. But when you create a non-working side contact, when they chew on the left side, the opposite side touches first. This is what is exactly happening. And so we have reversed the cycling in pathway. So what did the patient do? the patient adapted. So the motion reduced. Therefore, the muscles reacted to the tooth contact and it limited the motion. This is, for me, is very, very important in understanding the link between teeth and muscles. And you see here, this is the non-working side. So I got rid of it because I introduced it. Because the patient came in and said, everything is fine. He said, there's no problem. And that's because our patients are very plastic people. They can adapt. That's why when we increase the OVD or the VDO, it's no problem. Patients have the ability to adapt. And it's that adaptation occurs in the higher part of the brain. But this is all interlinked to the muscles and the joints and the teeth. So as we start to develop more in our occlusion evolution, we start to look at more different devices. This is a fully adjustable articulator that I bought to try and design better teeth and reduce the amount of adjustment I need to do. So what we recognized within the neurological signs, and sometimes the neurologists call it cortical remapping, so that when we are doing a change in the occlusion, there's actually cortical remapping going on. So we call that occlusal neural signature, because what we know is that patients have this neural signature in their brain, but with cortical remapping, they can adapt to the new signature, but some people cannot. And it's the ones that cannot adapt to it are the ones that keep coming back, telling you that their bite is not right. The occlusion is not comfortable anymore. It is changed. Yeah, so this is what happens. So the occlusal neural signature can be changed with cortical remapping in patients that are adaptable. But when your patients are not, then they keep chasing you to try and adjust their occlusion. And you have to be careful with these people. So we started to use more digital technology. This is the DNR cardiacs. So me recording that digital movement so that I can design better restorations that replicate function. So within our checklist and our analysis, we are doing a facial analysis. We are looking at the healthy TMJ muscles. We are doing an aesthetic analysis and looking at the overjet overbite with phonetics and function. Because in our data collection, we need to collect quite a lot of data. And the more data that we collect, the better we will deliver the end result. So in my deliverability, I use module for TMJ motion analysis and teeth design. I use EMG data from Teethan to be able to look at the health of the muscles and the activity of the muscles in function. And then I also use a device called T-scan, which is a pressure sensor, to allow that I can develop the bite to be more equal. So the muscles react more favorably to it. And you see in the middle picture, these are the Teethan sensors applied on both temporalis and masseter muscles of both sides. So why do we want to do it? It's because it's mastication. That's one of the main jobs that your teeth are designed to do. They are designed to chew. And therefore, if we understand mastication, then it means that we need to design the teeth to do that job efficiently. Because if we don't, there is an altered digestion kinetics, there's a change in macronutrient availability, and therefore potentially over time, we have impacts on our stomach health. You affect your stomach health, you affect sleep, you affect exercise. So what we realize is our teeth are a very important jigsaw piece in the design of our work. And what we're trying to understand with motion is that it is all related to this. So when we ask the patient to open and close, as they open, this is all dictated by the muscles, lateral pterygoid muscles involved in opening. Then the patient moves laterally and closes. And it's the closure is the elevator muscles, your medial pterygoid, masseter, temporalis. These all bring the jaw down so that you can break the food. The vertical slice, the last 1.5 millimeters, last 2 millimeters, these are teeth. So you cannot separate teeth from muscle. They are all interlinked. And so when we look at the design of our teeth, it is the cycle in and cycle out pathway that if we have healthy muscles, we can design the teeth correctly. And so using Teethan helps me spot the patient. But I know that if I improve the teeth, the muscles should get better. If we look at Kobayashi's or Akiyama's article on this was based around Prochel's article, which showed 14 recognized patterns. What we recognize is that we have patients that have different types of chewing patterns in healthy people. This was done on 50 people. So what they didn't do was look at the teeth positioning, the actual design of the teeth, to see what these patterns related to. And this is what we will hopefully be able to do over time. So when we get our patient to chew, we are looking at the actual motion of the patient. And the motion of the patient for 90% is muscles, and the last 10% is teeth. So we have to have healthy muscles. You put the teeth in the right way, the muscles will react favorably. So this is the teeth contacts in the last 1.5, 2 millimeters. So what we started to do was look at motion and the design of teeth related to muscles. So when we look at teeth designed on just an average value articulator, look at the difference in the shape of teeth. You see here the cuspal heights are different, the cuspal inclines are different. If we look at the cycle in and cycle out pathways of different cusps, if you design it using function, look at the similarity in the incline. It's all the same. They are all the same. So we know that if we design the teeth, it will improve the muscle health. So we did this with multiple cases to validate the research. And we recognize that if you use motion, then you will get similar inclinations of teeth. But if you have average value settings, you have different cuspal inclinations. That means the forces are different. Now the muscles react to that. How do they react? They reduce their activity level. So in some they reduce, in some they increase, especially if you infroclude the restorations. So we use motion to be able to see what the patient is doing. So this is me recording the motion data so I can design the teeth. So the patient will now move their jaw to the right, to the left, to the left. So we can then design the teeth. Once we break the food down, the food is ready to be swallowed. And so the muscles then activate the swallowing. So your masseter temporalis, this starts your swallowing process. So what we will do is we'll start to go through some cases to show you the collection of the data. Just to give you a little heads up, it's Ramadan here, so I'm fasting. So we will finish a little bit earlier, just so I can break my fast. So this is case number 1. So we collect our data. So this is the suitability. We collect our photographs, incisal view at rest, dynamic smiling, full face retracted. So we have our measurements. So we know that whether I am increasing the length of the teeth, I am doing some soft tissue work. This is all important in our data collection. So we do our smile design so that I know where to put the teeth in the right place. You see here from the top picture, the incisal length when the patient is at rest is good. So we can't make the teeth too longer. So we need to take the gums up. So then we do soft tissue surgery. Then we start to do our digital wax up, and I collect my EMG data. Now, when we look at the data here, you will notice reds on most of the things. So half is red and half is blue. So the red is telling us that there is an issue with the muscles. So in this top right-hand corner of the picture, you will notice 55. That is giving us an overall score. So the one reason I like Teethan so much is that it simplifies your data collection. You're not reading the micro EMG activity. What the data does it all for you. It actually gives you numbers so you can see, and it also tells you what is normal. So you see here, the impact data in this patient should be 85%. His impact data is half. So he is at 50% activity level. So the patient has some problems. And this also relates to his teeth because he has less teeth. We do our facial scanning, we do our planning, and we also collect our motion data. So he's a type 2 motion on the right and a type 3 on the left. If I redesign the teeth, does that improve his motion? Well, let's see. This is his cycle in and cycle out pathways. So we design the wax up using motion data. We place the teeth in the right place. He had some missing teeth as well. So this is all the planning. My cycle in pathways are all similar. We use the data that we've collected to design the wax up. So here we are designing function. And the teeth are all designed for mastication. This is then transferred into a mock-up. So I can test this new occlusal scheme, and then I transfer this into his finals. He's had implants, so I've placed implants on him, and I've done full mouth restorations. Now look at the design of the restorations. All the cuspal inclines in cycle in are the same, which is what we want. It's perfect. These are the anterior restorations. And this is his motion now. So is he starting to chew better now that I've designed his teeth? Look at how well he moves now, much more smoothly. So he's gone from this to this. When we look at the data collection now, look at how I've designed the restoration cycle in, cycle out. So we've now given good data to the muscles. This is the motion, right and left. Look at the cycle in and cycle out pathways. They have changed. And look at his motion. You see that the top picture is his motion at the start and the bottom is the motion at the end. So we have a different cuspal inclination, a different cycle in and cycle out pathways. These are the restorations at the end and the smile. But what about the EMG data? Look what happened to all of his data. His impact data, if we look at this slide, everything improved. His health, his muscle health improved. His impact data went into the normal range. His asymmetry index, which is this bottom right one, is now perfectly symmetrical. It's 0.84%, and that's slight prevalence to the right. So if we design the teeth combined with the muscle data, we see that the patient gets better. We see the temporalis activity is within normal. His barycenter is posterior, which we like. We like the contacts to be on the posterior teeth. So for chewing, we like that. If you look at his barycenter at the start, 7.4%. He was at a 10th. So because he had missing teeth at the back. So you see what happens to the muscles when we change the teeth. The muscles get better. This is a more complicated case. She had some failing implants, aesthetic issues as well. This is the sort of the start and the planning part. So we did a smile design. And then we start to collect her muscle data. Look at her start. Her actual muscle activity level was at 250%. So she was clenching a lot. That's why she was damaging her teeth. But everything was asymmetrical. Now she has missing teeth on the right. So this is a phased plan for her. We've got her into improving her mastication, her muscles, and so on. So everything is, not in a good position at this stage. So what we do is we collect the data. Yeah. So here we use the motion data to find the joint position centric relation. So here I'm planning where to place the teeth. You see here, this is the first tooth contact. I want to increase the OVD. So here's a cross section. So her first tooth contact is on the upper left too. So what I want to do is open the OVD. You see here, you can just see, fantastic. So I want to basically, from this reference position, increase the OVD, the VDO, and measure it. So there's 0.6 millimeter, 0.2 millimeter at that stage between centric relation and centric occlusion. Now I'm going to open the OVD to my desired amount. I want to open the mandible up to give me more space and give me a better overbite and overjet relation. It means that I will prep less heavily on the buccal of the lower teeth and the palatal of the upper teeth. Here I measure what OVD I want. I've measured here. I've increased the overjet by 2 millimeters. So we have a good overjet. It means I can add a millimeter palatally. I don't have to do much prepping on the upper labial and very little prepping on the lower. So in this situation, it helps a lot with planning. So I have a better relationship. We then extracted the implants. So at the moment, she's had her upper arch and lower arch restored, but we haven't given any implants yet on the right side. She needs some implants on the right side. So look at her motion. Yeah, look at how she is chewing on the right side. Look at how she's chewing on the left. So she's chewing very up and down, very little motion, because she knows her teeth are not healthy. So what she's doing is she's actually restricting her motion. And actually, if you look at how if you look again, look at how slowly she moves on the right side chewing, whereas the left side is a little bit better. Yeah, motion is a bit faster. Right side is much slower, more protected, because she has less teeth missing on, she has more teeth missing on the right. We design the wax up, we transfer it in a mock-up. So this is just composite mock-up transferred to the patient so we can test the new occlusal scheme. And then we transfer this into the final. Look at the design of the cuspal inclines, all designed by motion. This is the end result. And the smile. But what we want to discuss is look at her change in her data. So we see here that she still has some red, but we are still within, not far from the norm. In the Barry Center, the norm is 90%, but she's still got some missing teeth on the right side. We actually improved everything else. The biggest improvement was her asymmetry index. She was 42% asymmetrical because she had all her teeth missing on the right side, so the asymmetry was on the right side. But look what happened by giving her a more balanced bite. We dropped her asymmetry index. Her masseter muscles improved. Temporalis doubled in health. The torsion improved from 80% to 88%. These things don't happen miraculously. I always collect the data 8 weeks after I do my restorative work. But, it takes time for these muscles to improve back to where they were. But she was back into the green zone. So what I've tried to share with you in sort of the time that I've had is, how do we improve our patients rehabilitatively? And if you look here, look at how her chewing has improved on the left, and the right still vertical, still protected on the right because she's got missing teeth on the right. But her left has really improved. So her left side is much better, whereas the right side still protected, still guarded. She doesn't like chewing on the right, but that's because she doesn't have any teeth on the right to chew properly with. Just some further, it's a brief talk, so I hope you've enjoyed sort of the brief part. I mean, this is the book that I wrote, Practical Procedures in Dental Occlusion. So, you can buy it on Wiley or from Wiley or Amazon. It's a practical book designed to give you how to go from simply doing simple restorative work. This is obviously more advanced and comes within the digital realm. But, this is something that if you want to purchase, it's available on Amazon. And if you want to contact me, then, I'm available on Facebook. So Riaz Saeed, email me on riaz.yar_dental. On Instagram, I'm riaz.yar_yar specialist. And this is my WhatsApp number if you need any help or anything like that. And thank you very much. Thank you, Teethan, for inviting me again. Thank you to Antonino.
Thank you, Dr. Villar.
Arranging it all, and the team at Teethan.
Of course, Dr. shared also his contacts. If someone has...
I thought I would finish early just because I wanted to answer any questions, and I break fast in about 12 minutes, so it's perfect.
Don't worry about it, doctor. It's not a problem at all. I have just one question that I will give you. Talking about centric relations, the centric relation. If you don't have a technology such Mojo, for example, if you with Teethan, you can help you for centric relation. If you don't have other devices, other technology that can help you with such a thing. This is the question that I received. Thank you.
Yeah. So if you don't have Mojo, so what you will do is you will still, yes, you can the Teethan. You will still design the teeth using your articulator. So you can use leaf gauge. I like leaf gauge because you are using the muscles to position the condyle, not doing it through manipulation. So I prefer using leaf gauge, and Teethan helps you in collecting your muscle data straight away. So if you have a patient, sometimes you have a patient who has myofascial pain, they have a lot of muscle symptoms. So with Teethan, you can spot these patients and maybe give some splint therapy first. And we've seen that with splint therapy, the EMG improves. I've got a lot of cases where, by just discluding the anterior teeth, discluding the posterior teeth, how the muscles totally, how they totally change. So Teethan for me is the only tool that you have that can tell you that the muscles are healthy. And for me, that's very important. So I always collect EMG data right at the start of all my cases so that I know sometimes I need to do EMG, I need to do a splint therapy before I do any design of the teeth. So that's why for me, Teethan is important. The Mojo helps you design the teeth in relation to function. But what Teethan does is helps you validate that you design the teeth correctly, but also it helps you diagnose early on if you have a patient who has a problem that they may need some therapy before you start restoring the teeth.
Thanks, doctor. I think that you, with split, talking about splints, you talk about it in the last webinar that you did with us was what splints and occlusion in comprehensive restorative care. Yeah. Yes, I remember. I also put the link here. Share the link. Say if someone wants to take a look to your previous clinical cases that you already explained. It was in 2021. Okay, I don't see any other questions. So, doctor, already I have. If someone wants to ask us something more, I can share the same contacts that the doctor shared with you before. And thanks a lot for your time, doctor. Thanks for your presentation. Thank you, and have a good evening. Good evening, everyone. Thank you. Thanks a lot. Goodbye.
Bye-bye.
Take care.